Hi, everyone. Thank you so much for joining us for this series of webinars that will focus on diversity, equity, and inclusion. I'm Dr. Denise Martinez, the Associate Dean of Diversity, Equity, and Inclusion at the Carver College of Medicine and an Associate Professor in Family Medicine. The goal of this series is to learn, reflect, and think about one's own ability to impact equity in your life and also here in your role at UI Healthcare. This webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. We appreciate you taking the time to learn more so that we can make UI Healthcare a more diverse, equitable, and welcoming environment for all.
Hello, my name is Nicole Del Castillo. This webinar is entitled How Did We Get Here? A historical look at health disparities and racism in medicine. The objectives for this webinar include identifying health and healthcare disparities, recognizing why health disparities arise and how this relates to the history of racism in America and medicine, and describe strategies to eliminate health and healthcare disparities. Health and healthcare disparities refer to differences in health and healthcare between populations. Disparities in health and healthcare are related but not synonymous concepts. A health disparity refers to a high burden of illness, injury, disability, or mortality experienced by one group relative to another. A healthcare disparity typically refers to differences between groups in health insurance coverage, access to and use of care, and quality of care. Health and healthcare disparities often refers to differences that cannot be explained by variations in health needs, patient preferences, or treatment recommendations. Health equity is when everyone has the opportunity to be as healthy as possible. Health and healthcare disparities are commonly viewed through the lens of race and ethnicity. However, they also occur across a broad range of dimensions, which includes one's religion, gender, sexual orientation or gender identity, age, disability status, socioeconomic status, geographic location, language, citizen status, mental health, or other characteristics historically linked to discrimination or exclusion. These groups are not mutually exclusive and often interact in important ways. Disparities also occur within subgroups of populations. For example, there are differences among Latinos in health and healthcare based on their length of time here in the United States, their primary language, and immigration status. Low performance on a range of health indicators, such as infant mortality, prevalence of chronic disease, such as cardiovascular disease, diabetes, or other conditions, reveal differences between racial and ethnic minority populations and their white counterparts. Cancer is a leading cause of death for most racial and ethnic minorities. African American men are more than twice as likely to die from prostate cancer than white men, and Latino women are nearly 1.5 times as likely to be diagnosed with cervical cancer compared to white women. African Americans, American Indians, Alaska Natives are approximately twice as likely to have diabetes as white individuals. Diabetes rates among Latinx individuals are more than 1.5 times more than those for white individuals. There are also disparities as it relates to differences in treatment for racial and ethnic minorities. There are differences in treatment of acute pain for both adults and children. There's differences in heart attack treatment, patient engagement, and also there's differences in overall being believed. So why is addressing, understanding, and eliminating health disparities important? Why do offices like the Office of Diversity, Equity, and Inclusion here at the Carver College of Medicine exist? Some view it as a social justice issue. Dr. Martin Luther King Jr. noted that of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. Addressing disparities is not only important from a social justice standpoint, but for improving the health of all Americans by achieving improvement in overall quality of care and population health. So, you were able to see the data as it relates to these disparities and why it is important to address health disparities. But why do health and healthcare disparities continue to persist? Disparities have been documented for decades, and despite overall improvement in population health over time, many disparities have persisted and, in some cases, widened. Dr. Kamara Jones, a physician and the former past president for the American Public Health Association, has described three key reasons why disparities arise. First, differences in life opportunities, exposures, and stressors, differences in quality care received, and differences in access to health care. The cumulative weight and interplay of all of these reasons, not one alone, is likely responsible for these disparities. Some would argue that racism can have detrimental impact on health and healthcare disparities. The stress caused by discrimination has been associated with poor health outcomes and health disparities. The psychological distress from discrimination or hate crimes that occur both directly and indirectly can lead to a general sense of fear, hopelessness, and anger that can develop into anxiety, post traumatic stress, and depressive disorders. Over time, chronic stress has been found to impact not only mental health, but also physical health. Let's first start by defining racism. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is race. Racism unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. This was noted by Dr. Kamara Jones. Race is a social construct defined as a grouping of humans based on shared physical or social qualities into categories generally viewed as distinct by society. Dr. Jones also explains racism as a three-tiered construct that operates on institutional, interpersonal, and internal levels. Institutional or structural racism creates differential access to the goods, services, and opportunities of society by the social construct of race. An example of institutional racism is the reduced access of medical care and overrepresentation in the penal system for African Americans. Within the context of the United States and other nations, structural racism takes the form of preferential treatment, privilege, power, access, networks, and access to opportunities were often available to white individuals, which often designates communities of color to chronic adverse outcomes. Interpersonal racism is a driving force behind race based assumptions about the abilities, motives, and intentions of others. It can lead to feelings of suspicion towards or lack of respect for others, as well as contribute to blatant acts of discrimination, such as hate crimes and bigotry. It can lead to feelings of suspicion towards or lack of respect for the other, as well as contribute to blatant acts of discrimination or bigotry, such as hate crimes. Internal racism refers to the negative psychological impact of racism upon the members of the stigmatized race. This can manifest as self devaluation, resignation, and hopelessness. It is important to recognize that individual experiences of racism are only the tip of the iceberg. The tip of the iceberg would be interpersonal racism. Below the tip sits a broader foundation of structural, institutional racism that is far more difficult to observe, but probably even more important with regard to shaping the well being of racial minorities. So let's look back on why health and healthcare disparities arise. As noted before, disparities arise due to differences in life opportunities, exposures, stressors, the quality of care received, and access to care, which are all impacted by institutional racism. So let's first look at differences in life opportunities, exposures, and stressors. Through institutional racism, there have been continued policies, laws, practices disproportionately disadvantaging certain groups based on factors such as their race, ethnicity, gender, sexual orientation, disability status, and so on. Institutional racism manifests in both material conditions, which include differences in quality education, sound housing, gainful employment, and clean and safe environment. And access to power, which include differential access to information, resources such as wealth and organizational infrastructure and voice, including voting rights, representation in government, and control of media. Therefore, we can see how institutional racism results in differences in life opportunity, exposures, and stressors, which in turn lead to health disparities. It is important to reflect on history and how examples like the legacy of slavery for Black Americans and the removal of American Indians or Native Americans off their land and onto reservations has shaped differences in life opportunities, exposures, and stressors for Black and Native Americans, and how this relates to institutional racism. Social determinants of health are conditions and environments in which people are born, live, learn, work, play, worship that affect a wide range of health, functioning, and quality of life outcomes and risks. Efforts to improve health in the United States have traditionally looked to the healthcare system as a key driver of health and healthcare outcomes. However, as we see from this chart, when addressing the factors that go into our health, only 20% include those moments in a healthcare environment. As we noted before, institutional racism is defined as a differential access to goods, services, and opportunities of society by race. With respect to medicine, we can view institutional racism as a strong influencer of the social determinants of health. Health disparities related to the social determinants of health include poverty related illnesses such as low birth weight, infant mortality, asthma, infectious diseases, cancer, depression, cardiovascular disease. Other health disparities related to the social determinants of health include unhealthy default decisions related to smoking or living in a food desert, toxic living environments, which are high in lead contamination or frequently witnessing trauma. In addition, living in an area where you're at greater risk of injury and suicide. Harvard professor Dr. David Williams shared the word discrimination often brings to mind historical examples of denial of voting rights, hate crimes, discriminatory practices, and housing in the justice system. But not all discrimination is conscious, intentional, or personal. It's often built into institutional policies and practices, such as mortgage lending, zoning, or school funding practices, which in turn impacts where you live, the quality of education you receive, or access to public transportation or good jobs, all of which are linked to health. Redlining, a discriminatory practice by which banks, insurance companies, and so forth reduce or limit loan mortgages insurance within specific geographic areas, especially inner city neighborhoods. Racial and ethnic residential segregation through redlining is considered a salient social determinant in the etiology of health outcomes and accessibility and utilization of health services and the persistence of health inequities. Highly segregated neighborhoods are often characterized by poverty concentration, economic disadvantage, community disinvestment, and lack of access to employment and educational opportunities. These factors have been shown to lead to increased risk for health problems, especially mental health, and exacerbate poor management of health outcomes. Physical conditions of segregated neighborhoods may be more characterized by poor aesthetic quality and signs of physical decay, such as abandoned buildings and graffiti, which have a negative influence on mental health. Community violence and low levels of political empowerment may contribute to poor health and racial and ethnic disparities. However, enhancing social supports and collective efficacy and increased positive social capital often provide a buffer against negative effects or moderate the impact of neighborhood economic and physical disadvantage. Access to providers, the quality of care, provider characteristics, and the density and type of healthcare provider are associated with the impact of residential segregation. Additionally, geographic differences in healthcare systems, factors such as HMO penetration and payment processes and procedures of Medicaid and Medicare also contribute to limited access for individuals and families living in segregated neighborhoods. One study found that physicians who worked in segregated neighborhoods were more likely to have a patient mix with a higher proportion of Medicaid patients and receive significantly lower reimbursements. So, next, we will focus on differences in the quality of care and access to care. First, we will look again at some of the history of racism in medicine and how that has impacted quality of and access to care. In 1908, Carnegie Foundation for the Advancement of Teaching invited Abraham Flexner, a professional educator but a non physician, to survey the quality of medical schools. Flexner's approach included an ideal in line with the German model of medical education, which predominantly focused on scientific and laboratory medicine. In the late 19th century, as many as 12 medical schools, Black medical schools, existed. These schools formed due to Southern medical schools refusing admission to Black students. By 1910, when Flexner's report was released, there were only 7 Black medical schools. Given the lack of resources and standards, Flexner recommended closure of all but 2 of the 7 Black medical colleges. Flexner offered no mechanism for population-based needs assessment to develop a workforce to serve the nearly 10 million Black Americans living at that time, despite his knowledge of this gap. His report reinforced segregated and unequal medical education and perpetrated unequal treatment along racial lines. The lack of financial support crippled and led to the demise of Black medical colleges located primarily in Southern states and placed significant limits on the educational prospects in medicine for Blacks over the next several decades. Today, one might consider the ramifications for the future of American healthcare if three-fourths of all medical schools close within the next decade. Community engagement would wane, research and innovation would become stagnant, and patients would suffer, and many might die without the adequate medical workforce. The Flexner's report greatly impacted the Black community. Historically, inspiring doctors studied and trained in their home states, where they had connections and support. Nationwide, either Black students were denied entry into white institutions, or several obstacles were put in place to limit their opportunities. For Black patients, few viable options for care were available, and it was often substandard. It would be more than 50 years before the passage of the Civil Rights Act of 1964 and the Social Security Amendments, which began to rectify segregation in education and healthcare. Medical organizations such as the American Medical Association have history of practices and policies that have ignored racial segregation, discriminations, and exclusion. Furthermore, the actions and inactions of these organizations resulted in limited access, resources, and medical education and training opportunities for Black physicians. The National Medical Association was formed after Black physicians were unable to join the American Medical Association. Exclusion from medical societies create a barrier to licensing, board certification, hospital privileges, and training and education opportunities for Black physicians and contributed to health disparities for Black individuals. Today, we can see the impact of racism in medical education, and organizations have impacted the number of underrepresented minority physicians. In order to reduce cultural and linguistic barriers, it is important to have more underrepresented minority providers. In 1970, Black males made up 2.5% of medical students, but now only 2.4%. If we look at the percentage of underrepresented faculty, it's only 7%. Though underrepresented minorities make up 37% of the population, but less than 10% of faculty positions, according to the Association of American Medical Colleges.
Additional ways that the closure of Black medical schools, discrimination, exclusion, and medical education and organizations have impacted minority communities. It's seen through compromising access and quality health care, which in turn has led to health disparities that include limited health literacy, lower levels of insurance coverage, marginalization through low physical access to healthcare institutions, which is seen through distant neighborhoods, crumbling infrastructure, underfunded healthcare systems, and this is especially noted for individuals in rural areas.
Low-income individuals also experience more barriers to care and receive poor quality care than high-income individuals. Disparities in access and utilization also affect individuals living in rural areas who have more limited access to private coverage compared to those in urban areas and face significant barriers to accessing care. Now let's look at the other level of racism, interpersonal or personally mediated racism. This type of racism can be overt, but it is more commonly unintentional and based on unconscious bias. Our attitude and actions are influenced by unconscious bias and can lead to discrimination despite our best intentions. This manifests in lack of respect, suspicion, devaluation, scapegoating, and dehumanization. In medicine, the consequences of interpersonal racism are evident in the form of healthcare disparities. As detailed in the Institute of Medicine's 2003 report on equal treatment, minority Americans are less likely than whites to receive many effective services across a variety of clinical settings. Examples include inferior pain treatment, lower rates of revascularization procedures after an acute heart attack, fewer prescriptions for beta blockers after a heart attack, less timely administration of antibiotics for pneumonia, less optimal care for diabetes, fewer prescriptions for inhalers in children with asthma, fewer cancer screening tests. All of these have been thought to be related to provider implicit biases. So let's review some of the foundations of racism in medicine and where racial biases in medicine may have come from. Over time, many definitions and categorizations of race have emerged, some influenced by science and medicine. Each of these categorizations has served to perpetuate oppression. By the 17th century, slavery was legally established in the colonies based on the notion of racial inferiority. This grave historical insult has had profound impact on our highly race-conscious society today. During American colonization and slavery, being Black was likened to primitiveness, where it was spread that Blacks were unable to control their basic impulses and drives such as anger, sexuality, and criminality because of hereditary defects. Carl Linnaeus was a leading Swedish botanist and physician of his time who developed modern nomenclature of organisms. He also described Europeans with multiple favorable attributes, while describing others with unfavorable and unflattering natural tendencies. Benjamin Rush, who was not only the signer of the Declaration of Independence, but also noted to be the father of American psychiatry and the founder of America's first anti-slavery society in America. He defined the disorder negritude as a mild form of leprosy that could be cured only by becoming white. Though Dr. Rush was against slavery, this disorder was used to justify the inhumane treatment of enslaved blacks. American anthropologist and physician Samuel Morton used skull size measurements as a proxy for intelligence, claiming that Caucasians' larger skulls gave them superiority. Dr. Sims was a physician who repeatedly experimented on enslaved women to develop the surgeries that made him a major figure in the field of gynecology. Policies that successfully forced Native Americans to agree to a land allotment plan used an assessment of heritage based on the degree of Indian blood. This, among other catastrophic historical insults, has led to long-lasting discrimination and health disparities among American Indian and Alaska Natives. Carl Jung, who founded analytic psychology, explained that many American negative traits were due to living together with lower races, especially with Negroes. In 1932, doctors began a study to monitor the progression of untreated latent syphilis on 400 poor African American men, mostly illiterate sharecroppers. These men were not told of their diagnosis. The doctors explicitly left the men untreated even after the discovery of penicillin, and they were actively discouraged from seeking treatment elsewhere. In 1950, in the aftermath of the Second World War and the Holocaust, the United Nations publishes a statement on race. This statement declared that there is no scientific basis for race and called for an end to racial thinking in science and politics. Despite calls to end race-based thinking in science and politics, they persisted in the United States related to Jim Crow laws that shaped segregation. Books and articles continued to emerge in the 1980s and 90s that attempted to link differences in outcomes to racial biological differences, despite little evidence to support these claims. Graham and Robinson argued that salt-sparing genetic variations was adaptive in Africa due to a chronic salt shortages. Enslaved Africans who possessed the variation were able to survive the salt deprivation of the Middle Passage. There is virtually no evidence for this genetic variation or even salt shortages in Africa. Rather, evidence supports the hypothesis that social and economic inequalities generate chronically stressful living conditions for Black Americans. In 2005, the FDA approved a drug intended for Black patients. This again assumes a biological and genetic differences that has yet to be defined. So we can see how there are numerous examples in American history that have contributed to and demonstrated interpersonal racism. In this context, considering historical examples like the Tuskegee syphilis study and ongoing discrimination in healthcare, it is hardly surprising that many Black Americans harbor a deep distrust in healthcare institutions and clinical research. This mistrust was highlighted in a study that showed that Black Americans are more likely to believe that physicians prescribe medications as a way of experimenting on people without consent, and that they themselves had been subjected to these experiments. This chart highlights that people of color generally face more access barriers and utilize less care than whites. This data shows that among non-elderly Adults, Hispanics, Blacks, American Indians, and Alaska Natives are more likely than whites to delay or go without needed treatment. You wonder how much of this is due to mistrust in the healthcare system. As a result of institutional and personal mediated racism, internalized racism is damaging as it results in self devaluation, resignation, helplessness, and stereotype threat. The system of slavery lasted approximately 250 years in the United States and inflicted on exponential number of traumas and abuses on the minds and bodies of Black Americans. While slavery was abolished with the 13th Amendment, racism and oppression have continued through systems strongly rooted in the history of slavery. The historical traumas that occurred during slavery and post-slavery, as well as race-related traumas and microaggressions that Black Americans continue to experience today, may have lasting consequences for the health of Black Americans. Black Americans live with a legacy of traumas from slavery and beyond, and their thoughts, emotions, and behaviors. Slavery and ongoing oppression may severely impact in Black Americans' sense of esteem, self-worth, and self-efficacy, and consequently, their self-care. Black slaves had to submit to survive and were punished for being defiant, mature, or independent. They could not express themselves. The enslaved could not adapt a healthy sense of self-esteem or invest in themselves and were unable to express feelings. In present day, these effects are seen clinically and broadly in society where Black individuals may suppress or deny anger and emotions.
Stereotype threat was first described in the psychology literature, where eliciting negative stereotypes in study participants led to stress and anxiety that resulted in lower test performance. The unpleasant psychological experience of confronting negative stereotypes about one's own race, ethnicity, gender, sexual orientation, or social status that can impair intellectual functioning and interfere with test performance. Associated with multiple poor outcomes, stereotype threat can lead to lower healthcare utilization, as we saw on the previous slide, higher stress levels, lower performance on neuropsychological testing, and higher blood pressures.
Strategies to eliminate disparities involve the medical care and public health systems, but clearly extend beyond these to include collaboration with multiple sectors outside of health, which include education, housing, labor, justice, transportation, agriculture, and environmental systems.
Now let's look at what we can do on a more individual level to help decrease health and healthcare disparities.
I would encourage you to try and become an advocate. Build trust, empathy, and self efficacy into your relationships with patients. Learn and teach others. Try to mitigate unconscious bias. Work to create non threatening strategies to address bias when you recognize it in a clinical encounter. Our office also provides several trainings, including implicit bias trainings. Here is a list of some of the trainings that we offer through our office: culturally responsive care trainings, upstander trainings, sexual orientation and gender identity training, implicit bias, patient identity harassment, and fair search and hiring practices. I would also suggest reading to learn more about the history of minority health and disparities. These books and reports provide an early analysis of healthcare disparities. In his classic 1899 book, The Philadelphia Negro, W.E.B. Du Bois provided a detailed characterization of the Negro problem in America. This book indicated that the higher level of poor health for Black were important indicator for racial inequity in the US. He argued that although the causes of racial differences in health were multifactorial, they were nonetheless primarily social. The Heckler Report was released in 1984 under the leadership of former HHS Secretary Margaret Heckler. The Heckler Report was the first effort by the U.S. government to investigate health inequity among racial and ethnic minorities. It directly led to the creation of the Office of Minority Health in 1986. Offices of Minority Health were additionally established in the CDC, NIH, HRSA as a result of the report. In 2002, the Institute of Medicine published Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, which I previously noted. Overall, it reported that racial and ethnic minorities experience a lower quality of health care than non-minorities, even when the patient's insurance status and income are controlled. An American Health Dilemma presents a comprehensive, groundbreaking history and social analysis of race, race relations, and the African American medical and public health experience.
In conclusion, the United States has struggled with a legacy of racism, and all levels of racism can affect health and access to opportunities for wellness. It is important to recognize that unconscious bias plays a significant role in shaping healthcare disparities, and there are ways to mitigate these biases and address it. Finally, recognizing, understanding, and addressing the effects of racism and bias on health can help you to become a better provider and a better healthcare team member.
You can request any trainings by going to our website, medicine.uiowa.edu/diversity, and you will see there information about our trainings, and there is a service request form on our website. As well, if you have any other further questions, or if you would like to contact us, you can reach us at medicine-diversity@uiowa.edu. Thank you.